Good afternoon, everybody. Thank you for joining us. My name is Jalene Johnson. I'm the program manager of the Northwest Regional Telehealth Resource Center. We're presenting this webinar for you today in partnership with the Washington Association for Community Health and also the Behavioral Health Institute at the University of Washington. This webinar will focus on informing participants about common myths, misconceptions related to telehealth. The presenters will equip attendees with the skills to obtain informed consent and safety plans with clients when providing telehealth services. The objectives of this webinar are to dispel common myths related to telebehavioral health based on the literature, to describe how to obtain informed consent of a client, to describe an effective safety plan when providing telebehavioral health services, and to identify 3 digital divide issues that describe how they impact the delivery of telebehavioral health services. Our presenters today are Dr. Bradford Felker. He is dually trained in both psychiatry and internal medicine. His career has focused on improving access and care for populations of patients who lack mental health services. His early career focused on developing, implementing, and evaluating mental health programs within primary care. This work led to the development and the national implementation of the core components of integrated care, known in the VA as a primary care mental health integration, or PCMH. Locally at the VA Puget Sound, he has led a team that implemented and developed the first PCMHI program that achieved national recognition and was rated as one of the top 10 PCMHI programs in the VA. This led to further national VA work and the development of curriculum to help promote PCMHI. Our next presenter is Kara Tal. She has more than 20 years experience in telehealth with a master's degree in nursing and in international education. She established the UCSF International Medical Services in 1996, building clinical educational telehealth programs teaching Asia, Europe, and the Middle East. From 2001 to 2015, she served as the founding director of telehealth services at the University of Washington, creating a new rural telehealth network, delivering programs and services across Washington and beyond. We also have Nikki Parasho, who serves as the program director of the Northwest Regional Telehealth Resource Center, creating and disseminating information and resources to expand and sustain telehealth in the in the NRTRC 7-state region. Prior to joining the NRTRC, Nikki served as the virtual care manager at Logan Healthcare in Montana, managing all aspects of telehealth delivery, expansion, and improvement. Her clinical background and years of telehealth experience in the multiple specialties strengthens her knowledge of the needs of healthcare providers and patients and translate into an intuitive approach in supporting and operationalizing telehealth best practices for healthcare organizations and teams. Just a couple more housekeeping items I wanted to mention. Please feel free to utilize the Q&A portion of Zoom to ask any questions that you might have. We will make sure that they get over to the presenters. And if you guys would like to introduce yourselves and mention your role and organization in the chat, that would be greatly appreciated. Without further ado, I'm going to pass this over to Nikki Parasho to begin. Thanks.
Thank you, Jolene. That was quite a mouthful. I would like to say thank you to David for inviting us to speak today. We're really excited to share. And without further ado, I'm going to start my slideshow and I'm going to kick us off with just a little conversation about what the Northwest Regional Telehealth Resource Center does and different tools and resources that we offer that hopefully you all can utilize. So do you see my slides? Great, okay. So as Jolene had noted, she is the program manager, and I'm Nikki Parrish, the program director here at the NRTRC. We are located in Salt Lake City. We're housed within the University of Utah, the Utah Telehealth Network. And we are also, we're a member of the National Consortium of Telehealth Resource Centers. So what that is a collaboration of the other 11 regional telehealth resource centers and the 2 national telehealth resource centers. We are funded by the U.S. Department of Health and Human Services, the Health Resources and Services Administration, and the Office for Advancement of Telehealth. Our objective is to provide timely and accurate information of telehealth across the nation. So as I said, there are 2 national TRCs, and the Center for Connected Health Policy is one of them. You would utilize this resource for information on federal and specific state policy. The CCHP is a nonprofit, nonpartisan organization working to maximize telehealth's ability to improve health outcomes, care delivery, and cost effectiveness. Their expertise in telehealth policy was recognized in 2012, and that is when they became the federally designated Telehealth Policy Resource Center. The other national telehealth resource center is the National Telehealth Technology Assessment Center, otherwise known as TTAC. Their goal is, and their aim is to create better informed consumers of telehealth technology. And they want to do this by offering a variety of services in the area of agnostic technology assessment. TTAC aims to become the place for answers to questions about selecting appropriate technologies for your telehealth programs. So a little bit more about us here at the NRTRC. We cover a 7-state region: Alaska, Idaho, Montana, Oregon, Utah, Washington, and Wyoming. Our goal is to advance the development, implementation, and integration of telehealth by sharing information and leveraging resources, and also creating a synergistic telehealth community. Our main focus is to provide technical assistance to providers, clinicians, patients, organizations, and networks by implementing and sustaining telehealth in rural and medically underserved areas. How we would like to do that are many ways. And one of the ways is by offering telehealth professional development. Prior to the onset of COVID, back when we all had in-person events and did kind of pony and horse shows and went to different organizations and universities and health centers to talk about telehealth, that's really how we networked and how we answered questions. People would ask for some training, and we would come and do hands-on training, and then the pandemic hit, and that all kind of came to a screeching halt. And so we really had to work with our advisory board members, who often, many of them are subject matter experts in telehealth, representing the 7 states. And we worked to create an online Telehealth 101 online training. So this is a free educational course that's housed in a Canvas learning management system. It does come with CMEs and is available to anybody. We also partnered with Washington State to create their state mandated telehealth training for any clinician outside of an MD or DO providing telehealth. That's also offered on our professional development listing. Some of the other resources that we offer are for patients. This also was a pivot back in 2020. Prior to the pandemic, usually patients receiving a telehealth visit were in a clinic or a federally qualified originating site of some sort. So they had support of clinic staff to manage the technology and to help them to reschedule appointments and just prepare them for the telehealth visit. Well, all of that changed, and all of a sudden patients were able to see a provider from the convenience of their home or their office or somewhere else outside of a clinic. And so really what we realized is patients needed guidance too. They needed to know how to have a telehealth visit. So on our website, you'll find a link or a tab with patient resources. And some examples of those are 20 things you should know for a telehealth visit, your patient telehealth checklist, and then also what to expect from a telehealth visit. We also put our heads together and thought, gosh, what other resources could help patients and potentially help providers? And we're excited to say that in fall of 2021, we launched a tool that helps patients and other providers search for telehealth providers, either in their state or in the Northwest region. You, as a patient, have the ability to go on and find a provider that offers these telehealth services. And you could maybe communicate that to your provider if you're looking for a specialty follow-up, or a provider could be utilizing this tool for their patient if they were sending them home to an area that didn't have the type of physician that they needed in terms of making a referral for these type of services. So this is also located on our website. We also offer provider resources. So not only do patients have to make a shift, but providers had to make a shift, because now distance site providers were now potentially in their home seeing patients outside of their clinic. A lot of things changed. Maybe they didn't have a standard platform with all of the waivers. There was just a lot of unknown. And so we work with the other TRCs to share resources and provide different tools for providers that are housed on our website. One of the ones that I'm really excited about is the Telehealth Services and Codes table. And what this is, it was just updated in 2022 with the launch of the physician fee schedule, but it provides Category 1, Category 2, and Category 3 codes, along with the interim service codes that are able to be utilized through the public health emergency. So all of the services that are available via telehealth by CMS, and then also some approximate reimbursement amounts. The NRTRC partnered with the National Rural Health Resource Center to create a guide for critical access hospitals on how to implement telehealth. The guide provides practical guidance on implementing and sustaining telehealth. It primarily focuses on Medicare outpatient telehealth services, but does include some Medicaid coverage and remote services. And though it is titled Critical Access Hospital Telehealth Guide, it is really, it is aimed towards any telehealth practice. An independent provider, a regional hospital, a rural health center, a rural health clinic, any of those type of organizations can utilize this guide. We offer an events calendar, so we think it's very important for everybody in the industry of telehealth or that's interested in telehealth to know what type of offerings are available, whether they're educational offerings, they're webinars, they're events, in person or virtual. And that being said, if you have an event that you want the region to know about, there is a submit event tab on this page as well. So you could share your event and we would put it and market it on our site. Telehealth funding opportunities, so a list of current federal, state, regional grant opportunities that are out there. Also, complex questions about cross-state licensure, and if it's so complex that we can't handle it, we reach out to our partners at the Center for Connected Health Policy to give us a hand. Emergency declarations, with the PHE in place, so many states had emergency declarations that we tried to stay in touch with R7 and determine when those emergency declarations were set to be rescinded, or if they were still ongoing, but just so it was a quick and easy place for people to get that information. And then we offer an annual telehealth conference, and the last 2 years we were virtual. Some of you may have joined us, and I have to say it was a huge success, but I kind of miss those days of in-person, the networking and relationship developing that can happen. We are hoping, fingers crossed, for a in-person hybrid event in September in Salt Lake City. Our focus this year is innovation in telehealth. We're really going to look at where AI and telehealth meet, where is that intersection, along with different RPM and RTM models, clinicians and patient experiences, and telemental behavioral health. So please keep your eyes posted for that. If you have a presentation you think you would like to share, we will be releasing the call for abstracts early next week. So keep your eyes open for that. You can also find that on our website. And then finally, I want to close with an event that's occurring next week. The NCTRC is working with TTech to put on a virtual healthcare technology showcase. This will be a 2-day event with keynote speakers and 5 different telehealth use case scenarios and the technology utilized to incorporate those scenarios. This is a free event, and I believe Jillian is putting in the chat the registration. So that's all I want to share with you today. Please reach out if you have questions, comments, or suggestions. And at this time, I am going to hand it over to Dr. Felker and Cara to share their presentation.
Thanks, Nikki. That was fantastic. And please, everybody call me Brad. That's what I'm used to. Brad, or hey, you, big guy, clean up in aisle 7. I respond to all of those answers. So what we're going to talk about today, I'm going to lead off, and then Cara's, we're going to tag team this. And so I'm going to stop first. And when the Washington Association for Behavioral Health first approached us, they particularly kind of asked if we could talk about ways that we could help better engage care, and how do you go about better engaging care between a provider and a client over a digital modality. And I thought what might be nice is to just have a very practical talk today about how do you set up that professional standard? How do you set up that professionalism in those initial appointments to create that environment that is optimal for quality care? Personally, as we move forward into more telehealth arenas and we start working from clinic to home or home to clinic or home to home, I'm actually worried that we're going to lose sight of that structure that is baked into a in-clinic or in-person appointment. And that when you start going to these other formats and working between, say, 2 people's homes, that you could start to lose some of that professionalism. And so what I thought I would do today is just go over some basic myths on some of the core literature. And so that as a provider, if somebody questions or has a myth related to telehealth, you're prepared to answer them and cite literature. And then just go over some just basic do's and don'ts over informed consent and safety planning. So hopefully that will help you kind of create this professional environment, which I think is the biggest step you can take to have promote engagement with your clients. Next slide. So I think I just talked about that. So those are going to be our objectives. I'm sure somebody, one of the benevolent overlords of this conference, needs you guys to know what the objectives are. So there they are. Next slide, please. So let's go over some myths and facts, which I hear all the time when I'm trying to set up or implement telehealth clinics. And I'm speaking today mainly about video teleconferencing. We can come back and talk about other digital modalities later, but when most people talk about telehealth, they're still referring mainly to clinical video teleconferencing, and that's what this talk's going to be geared at. So you hear it all the time. Well, you can't have as good a diagnosis unless it's in person. Well, actually, the literature would show, and what I'm citing for you are what I think are some core papers, would show that you can do just as good or just as well as making diagnoses over quality video conferencing as you can in person. Another thing I get all the time is, oh, the treatments just aren't as good as they are in person. Well, once again, if you look at the literature, it would tell you you can do just as good as you can in person. Now, if you're actually listening to me, and I know it's after lunch or whatever, but you're noticing I'm saying just as good. So if you read these papers, they use something referred to as non-inferiority methodology. So the papers, the projects, these research projects never set out to say they're better than in person, but as good as. So I think that's an important point to make. Next slide, please. So this Ruskin paper, which I referenced on the last slide, this is really often cited as one of the first real core landmark studies showing that clinical video teleconferencing is as good as in person. A very well-designed, randomized controlled trial where they used a good objective outcome measures and really showed that treatment over video teleconferencing for depression was as good as in person. So if you want that one paper that demonstrates that, I would go to that one for those doubting Thomases that you might have to deal with. Next slide, please. Some other myths and facts. Well, we get this one all the time. Is, oh, the elderly don't like it. They're not tech savvy, blah, 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 blah. Well, I'm here to tell you, and it's really now, it was first, I've been doing this telehealth for about 10 years. I kind of came to telehealth through my previous work in integrated care, trying to think up ways to improve the quality of care that in rural clinics, and sort of developed an interest in this. And we heard this all the time. Oh, the elderly, particularly in the VA, a bunch of old vets, you know, they don't. No, not true at all. In fact, the elderly love it, and you should not sort of dismiss them as not being tech savvy. They might need a little help, but they really appreciate the convenience of it. If you start talking to them and saying, you know, you don't have to drive 40 miles down the highway with your aching back, then hike across an acre of a parking lot to sit in a waiting room for 30 minutes to see your provider for 20 minutes. They can say, I can get this done and out to the golf course today. I'm all in. They also really appreciate the access to all kinds of providers. So if you built your telehealth system well, it's well interconnected. So you've got access to all kinds of different providers. Today's technology is not that complicated. It's easy to talk. You can get large font. And quite frankly, a lot of them are already FaceTiming with their family and grandkids. So this is a common myth. This was often used as one of the issues around the digital divide that Carl will talk to later, but it's really being borne out that the elderly are totally cool with video teleconferencing. Next slide. Here's one we get all the time. Oh, providers and patients, they don't like it. They'd much rather be seen in person. Well, not so much, actually. When you talk to clients and patients, they actually prefer, in many ways, telehealth. They feel like they have better eye contact and they feel more connected to their provider. Think about maybe the last time you went to see a busy primary care provider and they're in that time rush, you know, and they're working on their computer and saying, how's that hypertension? How you're on your they prefer this much better now because they can feel much more connected, and they have this good eye contact. They report less anxiety of being forced in the room with them. Once again, the better access to specialists, reduced travel time, and they feel just safer. There's a reduction in the power relationship between the provider and the client. It's also seen as a safer space. So you can imagine if you're a provider working with very dangerous patients, it's certainly a lot safer to be doing it virtually. But more likely what you usually get are clients feel safer. I work in the VA. Unfortunately, we have a lot of veterans who are victims of military sexual trauma. So what could be more triggering than asking someone who has PTSD due to military sexual trauma to wait 30 minutes in a busy waiting room full of potential triggers of other people who could be potential offenders. So there's a lot of information out there that actually patients and providers, they kind of dig it. And here's some more papers that support this. Next slide. Here's one we get all the time too. Only stable patients. Oh, they got to be really stable. They can't have any issues going on. And when we first started doing telehealth, this was what was expected, you know, was that they had to be rock stable to go into this. And I remember looking at the criteria thinking, these people are more stable than I am. So they don't need any help. And so we started in our clinic, we started to purposely push the boundaries. And I think that what we learned was clinical video teleconferencing is just a tool. It's just a tool. It's not going to make you any different provider than you are already. It's not going to make the type of team, the type of clients you care for any different. Now, another talk we might do in the future is on advancing other digital modalities. And frankly, I think that's going to revolutionize mental health and change everything. But we're not talking about that today. We're talking about clinical video teleconferencing. So it's just a tool. So really, it all depends upon, as you think about your clinic, who are the clients you're going to provide? Who are the providers? What kind of structure do you have in the clinic? And how can you make it compatible so that CVT, clinical video teleconferencing, is safe and reliable? And here's a nice paper that Megan McGinn on our team wrote about how to sort of think through all these factors on safety and who's appropriate for clinical video teleconferencing or not. Next slide. Okay, before, I'm not monitoring the chat. Maybe I should be. I'm a simple guy. I can't do too many things at once. Before we shift gears, any questions on myths related to telehealth?
Dr. Felker, I haven't seen any questions in the chat or Q&A, so
right.
You're good to keep going.
All right, cool. So let's talk about informed consent now. This is really an interesting topic that's evolving. Actually, I was looking at this material earlier today, and I'm actually going to be doing an in-depth talk on this and safety planning for the 301 series through the BHI later in March. So if you want to come back and see us, Carl, we'll talk about that at the end. So do's and don'ts about informed consent. I think it's really important. In fact, I think it's now, based upon my reading, required to do. But there is not any standard related to this yet. Why is it required? Well, it's the right thing to do. Remember, telehealth is sort of a recommended form of treatment. So you really need to go through the informed consent as though you're recommending any other treatment. Also, I like going through the informed consent process because it gets us back to what we were talking about earlier about establishing that structure, establishing that professionalism that you need to create that environment that's going to help assure a quality professional encounter. As we all know, it's a lot harder to go back and add structure later than it is to add structure from the get-go. So taking this very professionally, doing informed consent, documenting that you did the informed consent, and it can be verbal, and that's allowed, but just kind of going over all of these points. So think back to whatever training program you went through. You probably had an ethics course, typically on a Friday afternoon, and they went over what are the elements of informed consent. There's 5 of them, and you can read those as well as I can. But really, when you're thinking about informed consent, and I'd recommend you create your own document, your own template, that then you refer with your own legal authorities over this. These are the 5 elements of doing informed consent for any treatment plan. You got to talk about what kind of treatment is it? Does the individual have the capacity to actually make a decision? What are the benefits? What are the risks? In making sure that the individual has the option to say no if they don't want to do it. And so documenting all that's really important. As I just said, don't assume this is obvious, and this is a good way to get that professional tone from the start. Next slide. So let's drill down a little more. How might that apply to CVT, or clinical video teleconferencing? Well, here I break down basically the 5 components that we just talked about. And you want to talk about the benefits of the telehealth. For example, improved access, decreased travel. You want to talk about the risks of transmission over the internet, hacking, but it's important to, that you're using HIPAA compliant software, confidentiality rules, the expectations of this as a professional environment. So no drinking, no drugs, appropriate dress, setting the boundaries upon how to contact and communicate. And then once again, letting them know if they don't want to do it, that's fine. It's always go back to the other way. Next slide. So some more, let's keep drilling down. So you really want to let them know if when you're using non-HIPAA compliant technology. At this point, early on in the pandemic, it was no holds barred, right? I mean, use whatever technology you got to care for your folks. But now as things have progressed, you really should be using HIPAA compliant technology. And if you don't know, you should talk to your IT people there and make sure you are, because there's all kinds of problems you can get into. You want to, some people send the consent ahead of time, have them review it and sign it and get it back and enter it. But it is allowed to have verbal consent. And once again, I would recommend that you have a template that goes over all this. And if you can do it to have the patient sign it and return it, or you can do it verbally and you document that the person agrees, and you document and sign it and so forth, and you put it in the chart and you're good to go. And then you also always want to make sure that you're creating the professional environment too. Private setting, sound insulation. I mean, there's a whole talk on setting up your office and helping them set up their office for professional space too. But in my mind, we're kind of beyond that right now. If you guys want to talk about that, I'm happy to. But today we're talking about these topics, but you should cover this stuff as well. It's all about, once again, how to better engage with your clients and set those professional standards so that they feel that they're entering into something professional. And I think they're more likely to engage as a result. Next slide. Some other do's and don'ts. How about some don'ts? Don't lose control of your boundaries, okay? Don't allow others to wander in and out of the session. Don't let, you don't want to be trying to work with them and they're texting and looking up at you and who knows what they're doing. You don't want them to record a session. However, let's face it, they're going to do it if they want to. So I always tell them, you're not supposed to record this. I'm not recording it. You don't record it. If I'm recording it, I'll get special permission. But that's actually, I would suggest to you, no different than doing in person these days, because in person with these cell phones now, they can just set something up to record, put it in their pocket, and you don't even know that they're recording in person either. So, but let them know, no recording. Don't allow, as I said, smoking, drinking. I know it's all legal, particularly if it's in their home, but and you'd be surprised how often this actually comes up. It's not allowed. It's not cool. It's not professional. And finally, don't panic when tech fails, because there's one thing I can promise you for sure. And there's very few things in the world of mental health, as you guys know, that you can guarantee. I will guarantee tech will fail. It always does. So it's going to fail. So it behooves you then to prepare and be ready with some safety planning, which we'll talk about next. Next slide. So before we go on to safety planning, any thoughts or comments on informed consent? I might add, while they're looking at the comments, there's a lot of information out there on informed consents, different templates, what you're supposed to have in it, who's required, what's required. Actually, our friends at the NRTRC are your best resources, because they're organized by states, and you can go, and I was looking at the Northwest NRTRC today, and they've got some great recommendations on there for informed consent. So go to the NRTRC. It's a fabulous site. So any thoughts or questions before we move on to safety planning? Going once. Bueller. Dating myself with that movie. All right, let's move on to safety planning. Okay, super important. This is all part of the professionalism too. What did I just say on the last slide? What is the one thing I can guarantee you? Tech will fail. And so you've got to be ready. And so some things that you want to think about right away is having a non-emergent plan and an emergent plan. And we'll talk about both of those. And what do I mean by non-emergent, emergent? Patient's doing well, tech fails. Now, what are you going to do next? Emergent, you're working with the patient that became imminently suicidal, psychotic. So you've got to invoke a plan right away. What do you do? And how do you protect yourself professionally? So one of the first things you always want to know when you start a session is, where is the patient? Where is the client? I work with, at the VA, we have federal supremacy, and I don't have to worry about state stuff. So I work with truck drivers, and they just pull over. I go, where are you today? I'm in Nebraska. Okay. And so knowing where they are, or I work with a lot of veterans up in Canada. I'm not allowed to care for them in Canada. So they drive over across the border to Blaine, and they go, Doc, I'm in the parking lot. I'm in a red car next to the kiosk or something. And so documenting where they actually are, and we'll get into that later, why that's so important. That's going to fail, I promise you. So get a good backup phone number for when the video goes down. So when the video goes down, you just pick up the phone and say, and you were saying, let's pick right up again. Once again, don't assume they're in every place, particularly if you're doing in-home based care. And like I said, have a non-emergent plan. What are you going to do when the video collapses? Is there a phone number? Is there a neighbor? Who can you contact? So on and so forth. And what I like to do is just paste that into a template that I put into each of my notes. And I'll share with you a template later that I like to use for safety planning. So this is just some basic thoughts right here. Next. Okay, so how about you're providing care to a clinic? And because we're going to do clinic first, then we're going to do home. So once again, you need an initial or follow-up safety plan. And like I said, I have templates I use, and I just cut and paste it, and it's a nice reminder for me to review the informed consent things each time, to find out where they are, to get the right phone numbers. So if you're working in a clinic, what I usually do is I check in early to the clinic and find out two names. One, who is the tech person there today? If I have a tech issue, who do I need to contact and what's their phone number? Because names change, phone numbers change. The other thing is, who's my clinical support? Who's going to be rooming the patient? If I have an emergency, who can I call to get them into that room to sit with the patient, and so forth. And so you want to find out who they are, because they change all the time. Their phone numbers change all the time. And so just like, hey, who am I working with today? Good. What's your number? Great. Let's go. That's all you got to do. You write it and you document it. E911. Okay, this is really important. I'm not sure how many of you folks know what E911 is, so I'm not going to grill you, but E911 is important to know about. So when you're working in, if you bear with me, there might be some, maybe you all know, I don't know, but I'm going to just go over it real quickly. If you're working with somebody in your office and you're both sitting here in a clinic, say, I don't know, Tri-Cities, I'm working in Richland, or I'm working in Spokane, or I'm working in Seattle, and they're sitting there and I got an emergency. I pick up the phone, I call 911. I go to it goes to the local 911 dispatcher. They send over whatever it is I need. Works, right? Problem is when I'm in one part and the person's somewhere else, right? If I call 911, local dispatcher is sending the police to me. I may need help, but that's probably not where the police or fire or rescue or whatever, they need to go to where the individual is. So this is why E911 is so important. That number, that's the actual number I'm giving you right now. So, and I document that in every single note I have. So it's always right there in front of me. You call that number and you tell them, where is the patient? And then they will contact the local 911. They will connect you to the local 911 person. That's why it's really so important to find out where that individual is at the start of each appointment. So that's the actual E911 number. Don't call and test it. do me a favor. I did. I got in trouble. So trust me, that's the number you want to use. Don't call and say, hey, I'm just checking out. Is this really it's the number. So don't do what I did and get in trouble. Okay. Document where you are, your phone number, and understand what protocols you work with in that clinic, and also understand what are some of the local resources available. So let's say if you're working in an outpatient clinic, what's the local ER you're likely to use, and get that information as well. Next slide. How about when you go to home? Basically, it's the same stuff, but you're not going to have somebody sitting in them or a tech person there. But you can sometimes get some information of like a friend or neighbor or family member you can contact in case of emergency, and get that information as well. There's the E911 number. Again, I put it in everything. And just as you would for the clinic, find out what the local ERs or clinics are in the area of the patient. Most of the time, they're not traveling truck drivers. Most of the time when you're working at home, home, same place all the time. So knowing what the local ER is, if you need to send them for sort of a semi, they don't need an escort, but you think they need to go. That's a good background information to have, and then you can document that as well. Next slide, please. So here is one of the actual headers I use. And so you could see it's just a nice, like, I'm not a pilot. I would be a disaster as a pilot. I daydream too much, but I like to think of this as my pre-flight checklist. So I paste this in the front of my note. I look over, I check on all these things, make sure I've covered all of them. I find out where the patient is, and so forth. And under setting, I'll cut and paste or type in where they are that day, and there's my settings. So feel free to use this as a template if you want, but this is one of the headers I set up here at the VA and at Puget Sound that we use. So there you go. Next slide. So to kind of summarize here, close. Who's appropriate for clinical video teleconferencing? So we're talking about the professional engagement. So hopefully I've helped you think about the literature base for doing CVT. I've helped you think about how do you do informed consent. And since you don't have the benefit of that professional building or clinic that has all that professionalism baked into it, you've got to create it now virtually. And we've talked also about setting up that safety planning. So the patient feels safe, you feel safe. Everyone should have confidence now in a good engagement. So you're ready to open the doors. Who's appropriate? Well, it comes back to what I was talking about earlier. The criteria are continuously loosening. Remember, CVT, just a tool, just a tool. You're not going to change who you are, not going to change type of work you do. So think about how you would use this tool in different clinical settings, and then build the structure around to take care of those clients with the appropriate team, support services, systems, and then link over video and use the safety planning and informed consent I just talked about. So basically it's being used everywhere now, ER, inpatient, consult liaison, etc. And once again, because Megan wrote such an excellent paper, there's the reference to that paper again. Next slide. So this is time for me to exit stage left and turn it over to Cara. Hopefully, I've been able to just make this, once again, I wanted this to be a really nuts and bolts, practical, boots on the ground presentation today. That's kind of who I am. I'm not a big ivory tower dude. I don't do well over there. I'm a veteran. I like kind of working in clinics. So basically, hopefully we've covered this literature. I've talked about the importance of informed consent and given importance about safety planning. And I've given you hopefully some good nuts and bolts to use, or at least to get started in your clinic. And so I'm going to exit stage left. After Cara is done, happy to take all the questions you'd like.
Dr. Felker, I think we could take this opportunity just to answer a couple questions that came up while you were speaking.
Sure.
One, Sean Kavanaugh would like to know if there is a link to your checklist that we could put in the chat.
How about you just share the slides?
Absolutely. Definitely. We'll get those out to you guys afterwards. And we also had a question from Mandy Pokorny. She says, does the more comprehensive consent, risks, benefits, etc., need to be done with every visit, or can repeat visits be more abbreviated?
No and yes. So do it well once first. Document it, go over in detail, just sense the structure. I like to sort of review some things each time, particularly if I'm seeing drift in the professionalism. Person's starting to show up and it's not taking it as seriously. It's a good time to review some of the informed consent aspects again. So no, it technically the whole meal deal does not have to be done every time. Should be done first time and documented for sure.
Great. And then just a comment from the audience. Jean Copey just stated, I couldn't agree more with your statement that tech will fail. Thanks for talking about this, much appreciated. And I totally agree. I think more often than not, if something doesn't work perfectly the first time, and that goes with anything in life, we kind of give up. And I think it takes some finesse and definitely trying and feeling the technology out before we kind of catch strides with some of those things. So thank you so much.
Yeah, you know, I'm actually not a tech guy. I'm not a techie. I just realized that these are very powerful tools that as a clinician, I need to start putting in my toolbox. And Cara will tell you, I am not a techie. You know, if there's a way for me to trip over the cord and disconnect one of our conferences, I will likely do it. But these are powerful tools that I think they're here to stay. And I always challenge, particularly residents I'm supervising, like, how good a provider do you want to be going into the future? You know, if you want to be good and effective, you're going to have to learn these tools and put them in your toolbox. You don't have to be techie, you don't have to write code, you don't have to do all of this type of stuff, but they're important. So I'm going to exit stage left and turn it over to the amazing Cara.
I don't know if I go that far. Yes, technology, best friend, worst enemy. And let's see if I can pull up the right slides here. Good. And okay, so that's me. And as you can see from the slides, Brad and I both do some work, a lot of work, and Brad is our consultant at the Behavioral Health Institute at Harborview Medical Center. And I'm going to talk a little bit about the digital divide, which I'm sure most of you are very aware of. So at the Behavioral Health Institute back in April of 2020, we decided to do a telehealth survey among providers. And it was really, in general, a needs assessment survey to help identify where behavioral health providers' needs were for tools and resources and training, because we had, you know, as COVID hit, the healthcare authority who was funding us said, boy, behavioral health providers really need some help because, you know, they're out there and they need to switch quickly to telemedicine and telehealth, and they don't have a lot of support to do that. So can you help them? So we did a survey to see if we could find out where the needs are. We had about 329 responses, and the majority of them worked in specialty mental health, SUD programs, and they were in clinical leadership, program manager, director roles. About 10% were from Indian healthcare providers, and about 204 organizations or practices across the state. You can see the numbers on the map there were our respondents. And one of the questions, this was not focused on the digital divide, but one of the questions was, what barriers are your organization's clinicians experiencing in being able to provide telehealth or even telephone services? And we asked them to check all that applied. And I'm just going to circle the ones that did tune us into the digital divide as this was all happening. So access to broadband or Wi-Fi, access to needed equipment, both at about 25%. And these are clinicians, not patients, but clinicians. They needed help setting up and using a laptop or the internet or providing telehealth programs. They needed help just adapting to using telehealth and telephone. So then we asked them also, what barriers to telehealth or telephone service are your organization's patients experiencing? And so again, I'll just highlight the ones: access to broadband, boy, a lot. Access to a cell phone, or the amount of data that they would need to be able to use the cell phone for telehealth services. Access to a laptop or a computer. Adapting to telehealth or telemedicine. Other very interesting things in here as well, including language interpretation and hearing. So that prompted us, well, gee, maybe we better survey some of the patients. So the previous survey, actually, there's a paper written on that. And if you're interested in that, I don't actually have the link handy, but if you're interested, I will give you our email address at the end. You can send us an email and ask any questions or request any additional resources. The patient telehealth survey took place May through August of 2021, and we're still kind of digging through the details. So this is not hot off the press because it's not even in press yet. But here's some information that came about as a result of that survey. So our goals were to get patient input instead of their providers, but patient input directly to help guide the evolution of telehealth services and to further identify access issues and figure out what's going on there. And the method that we used was that we sent the survey link to providers and we asked them to distribute or to administer to their patients. We specifically said, please share this broadly, and we want to include those who are receiving behavioral health services, including via telehealth, those who have experienced barriers to using telehealth, and those from varied cultural and linguistic backgrounds. The survey was voluntary, completely voluntary and anonymous. It was made up of 22 questions, and it was made available in 10 languages. And we had about 1,300 respondents. 87% were completed by the patient, and the remainder were completed with the help of a provider or some sort of assistant. So just to give you some background on who responded to this survey. So we asked what the age was. As you can see, it's more towards the 25 to 44 age range, but a good chunk between the 45 to 64, and not a whole lot of folks older than 65, certainly 0 to 11. So you can see the age ranges there. Which gender do you identify with, and heavily female, followed by male, and then a mix of the remaining. And then which of the following best describes your race or ethnicity? So this was heavily skewed toward white or Caucasian, although we did get some participation from folks from other racial and ethnic backgrounds. And about 75% of the respondents were located in urban or suburban areas along the I-5 corridor and Spokane. So keep all of those in mind as we're looking at these results. So we also asked, do you receive mental health or substance use services in a language other than English? So not very many of them did, only less than 10%, more like 5-6% did. And similarly, do you use an interpreter? So a few more did use an interpreter, but again, it's heavily skewed towards English-speaking patients. And then have you received telehealth services from, for your mental health? Sorry, I have to crunch my thing down because I'm covering my own slides and I can't read what I'm seeing. Have you received telehealth services from your mental health or substance use provider? And we define telehealth as receiving services by video, phone, text, or email. And so a lot of people responding here did receive some services via telehealth through that definition. How have you used them? So what kind of telehealth services? The greater majority was by video, audio video, followed closely by telephone only. And then there was actually a good handful of people receiving care through text or through email. So then we asked, do you have good access to the internet or to Wi-Fi service? You can see I included in here the number of people of the 1,300 who answered and who skipped. So you can see that just under 1,000 people actually answered this question. So good chunk of them did, but again, keep in mind the sort of skews before, but still around 8% said no, they don't really have good access to internet or Wi-Fi service. And is it affordable? And about 55% yes, it is affordable, but 20% said, a little bit more than 20% said no, and then a little more than 20% said that they don't pay for the services themselves, so they're getting them somehow at someone else is providing for it. So then what is your reason for not receiving telehealth services? So of the 52 who answered the survey who said they had not received telehealth services, these are the reasons that they did not. And so one of them, I have difficulty setting up the technology or the equipment. I don't have reliable access to phone or computer. I don't have reliable or affordable internet access. And I circled that because as I read through what people wrote into the other box, it mostly was those three topics as well. Difficulty setting up, didn't have access to a device, didn't have access to the internet. So how did it work for you? So my device was easy to set up and it worked really well. Close to 70% said, yep, that worked for them all of the time. About 30% said some of the time, and a small percentage says it didn't work at all for me. I could easily find a private place for my session, which has become an issue with telehealth into the home, and just under 70% said yes, they could. It almost mirrors what the device setup was. About 30% said some of the time, and maybe about 5% said that they couldn't find a place to have a private session. And then I could clearly talk or text with my provider and in my preferred language. Again, remember, most of these people were English speaking, so 90% said yes, they could do that. But a good chunk, 10%, said only some of the time, and a small, probably just a couple of percent, said none of the time could they hold the service in their preferred language. We asked, what did you dislike about your telehealth services? And this was an open-ended response. And I actually read through all 689 responses, and a good majority of them were comments related to technical challenges, poor connectivity, low bandwidth, that kind of thing. Anything else you'd like to share about your telehealth services? So I pulled out some representative samples. So this experience amplified the importance of current technology rather than my decade-old laptop and outdated phone, which are expenses that I now must consider. So again, access to device, access to a current device. I think telehealth services are great as long as you don't have computer problems and aren't dealing with mental health issues. So I think that was probably a bit of a tongue-in-cheek response. Making cell phone service easier for the homeless and low income. So that was something that came out quite a bit. Sometimes there's a problem trying to get into Zoom at times for me and for the provider. So again, using the technology challenges. And then broadband needs to be affordable to working family incomes as well as generally available in the area. So again, comments about access to broadband and Wi-Fi and things like that. That's the summary of that survey. And looking back on it, that we would have done it in many different ways and asked different questions, but it certainly pointed to some of the digital divide issues that folks were experiencing. And this is a slide that came from the Chartist group. As you can see at the bottom, it says this was based on several million claims records from January 2020 through January 2021. And as you can see, prior to the pandemic hitting, even in behavioral health, the average number of providers in all of these specialties who were using telehealth in some way was just over 2%. Then, of course, it jumped up. Everybody had to try to pivot to telehealth when the pandemic hit. And then as it started the COVID started easing a little bit, you can see that the medical specialties, surgical specialties, and primary care dropped off quite a bit. But behavioral health has really stuck way up there in the 70th percentile. Not that they're doing all of their service by telehealth, but they're providing some sort of services by telehealth or telebehavioral health. So I think we can all agree that it's probably here to stay. And then Brad may have referenced this a little bit, and if he didn't, if you ever have a chance to hear Brad talk about new digital health modalities, you ought to, because he gives a great lecture on that. But as we know, it's not just video teleconferencing. We have new digital modalities, the digital front door using patient portals and self-scheduling, remote patient monitoring using sensors, database management to manage all of that information that's coming in from sensors and reporting between appointments, and then texting and chat and artificial intelligence and apps, which all of those are, especially the bottom, are really becoming prevalent in behavioral health. And as always, behavioral health is really leading the way in terms of telehealth and digital health. However, before COVID hit and when we were at that 2.1% utilization rate, we always kind of heralded telehealth as the way to really solve some of the access and equity issues in health. But then when everybody started using it, some equity and access and equity issues within telehealth started bubbling up. And again, I'm sure most of you are aware of this. So as demonstrated by the survey that we did, technology access is a big issue. Getting access to devices such as telephones or computers or tablets or things like that to be able to access telehealth modalities. And then getting access to broadband, and that's kind of a twofold problem in terms of affordability. Can you afford to pay for that broadband access? And then availability, and we often see that is an issue in the rural areas more than the urban areas, that they just don't have access to enough bandwidth to be able to participate in a telehealth encounter, or you're competing for bandwidth when you're working from home and studying from home and trying to have an appointment at home too. And then there are, of course, language barriers and cultural barriers. As noted in some of the slides, people are having a hard time utilizing the technology and getting access to services in their own language. And some of the technology is helping with that, but it still remains a problem. Cultural barriers, there are some cultures that they don't, maybe that they don't trust the technology. They feel like there are too many security and privacy risks, that, people might be recording them or, tracking them or something like that, or they just aren't comfortable using the technology. And then people with hearing or visual impairments, that's something that we didn't focus on very much in the survey. I wish we had, but that's an issue that has been bubbling up in some of the training series that we've been doing. We've gotten feedback that they're unable to access some of the information that we're providing because they're visually impaired or something. And then digital literacy is a problem, as suggested again by the survey slides, that people might have the devices, but they don't really know how to use them, or they're not comfortable using them. And as Brad suggested, it's not always the old folks, but sometimes it is the old folks who are not comfortable or not knowledgeable enough to use the technology. Again, language issues, cultural issues, maybe new immigrants, and maybe the social determinants of health factors may play into this as well. So I think Jolene and Nikki and I were all on the Washington State Telehealth Collaborative meeting this morning, and maybe a couple of you in the audience were too. And someone from one of the major health plans had done a similar survey, which was great. And I think they're going to be publishing that soon, but you can go back and see the slides if you want to go to the Washington State Telehealth Collaborative website. They'll probably publish those slides. It was very interesting for me to see in their slides that they found that when they broke out comfort with using the technology, the BIPOC communities were more comfortable using it and more likely to use it than the non-BIPOC communities, which is really interesting. And boy, that would be a great thing to dig into. So I'd point that out because I think we do make assumptions, like Brad said, about the old folks, and I'm beginning to reach that level myself. But we can't make assumptions that sometimes the digital literacy is not a problem based on age or SDOH factors or language. So anyway, to keep that in mind. And then there's the hesitancy about using telehealth and the belief in the quality. Is this as good as? And Brad talked about that in his slides as well. And unfortunately, patients don't all see that in those types of studies. Providers do, and I know Brad has referenced in other talks that sometimes providers are the stopping point, the barrier to using telehealth because they don't trust it. Patients, we have found, I don't know if you remember the ad from many decades ago, probably, the try it, you'll like it. It seems that folks who, once they try telemedicine and use it once or twice, they, for the most part, they're pretty happy with it and are pretty happy with the the increased access and convenience that it offers. And that came across also in the slides that were at the collaborative meeting this morning. So just some points to think about in terms of access and equity and digital divide when we're providing telehealth. This is a big area that lots of people are looking into in terms of research and finding solutions. And so I just wanted to pull up some solutions. I don't think anybody has completely solved it, but there are a lot of people working on it. So Washington State actually has a state broadband office, and they're really focused on getting all residents enough broadband to be able to participate in school and work and healthcare activities. They have a bunch of resources there. I put this on here because they're encouraging people to take the broadband speed test because they're collecting that information to map out where they need to increase access to broadband. There's a list of Wi-Fi hotspots. Just recently, the State Office of Commerce actually awarded for digital Navigator grants for services statewide. So digital navigation is, I think I talk about that in the next slide, is kind of a new thing that's come out of this huge increase in use of telehealth. They're also focused on preparing local communities and tribes to compete for new levels of broadband funding that are coming down from the federal folks. They also hold a digital equity forum that I think is open to the public, and they also have broadband action teams. So the broadband office is doing a lot of work to try to increase access to broadband. The USDA, U.S. Department of Agriculture, strangely enough, they have a rural utilities service, and they have 4 different programs that fund broadband deployment. Plus, they have a grant program that comes out, I think, every year that funds distance learning and telemedicine software and equipment. So that's something to be aware of. There are other federal programs like Lifeline and the Affordable Connectivity Program, which used to be the Emergency Broadband Benefit Program, that provides discounts on obtaining devices and ongoing discounts for internet services, again, for low-income households. In terms of language and culture, the Washington State Coalition for Language Access is working on some digital divide issues in this area. They also have an interpreter and translator directory. I mentioned before that the technology sometimes is offering some capabilities for interpretation, and I don't know if you can see it on here, but Zoom at least is offering a closed captioning option on there, and I heard from someone recently that there's a translation option as well. I don't quote me on that because I just heard that this morning, but so some of the technology is coming forth with some closed captioning and interpretation things. Zoom does have links to pull in interpreters. And I think also that some groups are using their cultural interpreters or language interpreters and training them on some ability to help patients with devices as well, and training them on how to use their devices. And then digital literacy, there's a lot of stuff. If you just Google digital literacy on the internet, you'll find lots of stuff, but some of the resources we found were telehealth for seniors, and they have a bunch of tech guides, tech boomers. Chicago Public Library has a ton of very detailed stuff about very basics, how to use your cell phone, how to use a laptop, what's the internet, that kind of thing. And then there's this new role that's coming out for digital navigators, as the previous slide noted, that provide either individuals or small groups the assistance with either accessing low-cost devices or services, internet services, providing some digital literacy training so that they know how to use those devices and services, and just meeting the clients where they are in terms of their ability to utilize and access telehealth. Is this a new team member? Maybe this is a new team member that you hire someone in to be your digital navigators, but I've also heard that again, like with the language interpreters, folks are cross-training people in existing roles, like in customer service or community health workers, to provide that digital navigation service as well. So I wanted to give you just a couple of more resources that come out of the Behavioral Health Institute. And the first one is the Tele-Behavioral Health 101 that we put together in partnership with the NRTRC. This is an online program, and it's a 6-part that gives the really basics of doing telebehavioral health. And what are we doing for time? Okay. And this first session meets the training mandate in the state of Washington that impacts everybody except for MDs and DOs. So if you haven't had that training, you can go online and get that. It'll lead you to print up a certificate of completion, and then you're done with that mandated training. As you can see, it's accredited by National Association of Social Workers. That gets all the therapists and counselor types. Because it's offered by the University of Washington, it also qualifies for continuing education for psychologists, and it also has CME accreditation. The 201 series was a webinar series that we offered last year, and we are now repackaging the recordings, and we're going to be putting into an online self-study very similar to the 101 above, same accreditation information. And then this year, we just started offering Telebehavioral Health 301, goes into a deeper dive about how to use telehealth to provide high quality services. And we just had last week, a presentation by the BRE Collaborative, folks who developed a telehealth guide over the past year and talked about hybrid models. You can see some of the topics that are coming up. So we encourage you to come and join. And I should have put a registration link on here, which I didn't. So if you're interested in doing, accessing any of these, please feel free to email us at bhinstitute@uw.edu. I'll show that, I think, on the screen. Yeah. So that's our email. If you have any questions for us, or if you'd like any of these resources, just let us know. And that's it for me. Any questions?
Thank you, Cara. That was great. There are actually a couple of questions in the chat. I'm going to go ahead and read them to you. Buck Rowland asks or states that this is wonderful to see this presentation. I'm wondering if any of you can recommend any organizations that are fighting for national standards with technology and or telehealth. So
Nikki, isn't that not the NRTRC?
I was kind of waiting to
put you on the spot there.
No, so that is, I think all national organizations are fighting with that. And I know that's high on our list to tackle in this new year. And, that is one thing that COVID really did, was point out that we did not have equity in terms of accessibility for telehealth visits, whether that was interpretative services or translation services. Those were lacking. So that is, that's a big push. So Buck, we can follow up and send some resources. I don't have any off the top of my head, but we can definitely send you a list of organizations that are working with equitable standards for telehealth visits. And I see Mandy wanted to clarify, by standards, do you mean by specialty or maybe benchmarking? And I think Buck, if you want to take, off mute and state, otherwise I could try and sum it up, or you could put it in the chat. Okay, I covered it, great. And then Janelle Squanner wrote the survey. Were there any community behavioral health agencies that serve BIOPIC individuals used to help collect the data?
We didn't work specifically with any agency to collect the data. We did partner with the Healthcare Authority, and they provided us with access to their listserv. And so we sent it out via the HCA's listserv to all behavioral health providers. So we hope that, we got some agencies that were serving BIPOC individuals that I think we could dig deeper into the data. I'm not sure it will reveal that without a lot of digging and figuring out, who responded and what kind of organization where they were. So, but it was broadly distributed across the state.
All right. Well, thank you. If I don't see any other questions in there, so I'm going to go ahead and wrap it up. There is a post survey if you all wouldn't mind taking that on close of Zoom. And I want to say thank you again to Brad and Cara and David as well. So thank you all, and we will send the slides out, and feel free to reach out with any questions.